Hey, KK, you know a bit about this. What happens when someone experiencing homelessness is discharged from the hospital?
Josh, I see that you're starting this off with your signature sarcasm.
There's no sarcasm.
Yes, there is. So here's what happens when a homeless person is discharged from the hospital. They go home. And home can be anywhere from a park bench to a tent in the city landscape. Do you see some issues with that, Josh?
Yeah, having worked in this field a long time and encountering folks after being discharged, it's not great.
Let's untangle it.
Let's do it.
Welcome to Untangling Knots. We're going to explore solutions to help reduce homelessness from two very different perspectives. I'm KK, the founder of a street medicine team here in Kansas City.
My name is Josh Henges. I work for a city to help them solve homelessness. I'm going to talk about how cities work to build long-term plans to reduce homelessness. I'm the most reasonable voice in the world of homelessness.
Okay, so today is episode 6, Kicked to the Curb. Do hospitals treat discharged patients equally? Let's untangle these knots.
All right, let's give a quick disclaimer. The views and opinions expressed on this show do not necessarily reflect those of my employer, supporters, friends, or family. And if you've got a problem with anything I've said, come to me.
And these views do not reflect those of my employer, my employees, my volunteers, or my family. So if you've got a problem with me, take it to Josh.
Let's go.
Let's untangle these knots. Josh!
Yeah. I think you're uniquely positioned to talk about this issue. So a lot of people don't know how disconnected hospitals are from the overall homeless serving system. In most cases, there's very little communication. Now, a hospital may have a relationship with one or two homeless services providers, but by and large, it's a mystery.
It is.
So you started Care Beyond the Boulevard to provide free medical care to folks in encampments, folks who are street level homeless and have absolutely nothing. You must encounter hospital discharges all the time. When you all go into an encampment, can you talk about what you see, especially in relation to folks who have needed emergency care?
Sure. So this happens daily on the streets in the United States. Everywhere that there are people experiencing homelessness, they're being discharged from hospitals without the same level of follow-up care that you or I would get if we were being dismissed from a hospital every day. I have tons and tons of stories of hospital discharges. But I think one of the things that we have to recognize is before we start talking about hospital discharges and saying, okay, hospitals are discharging people to the streets when they shouldn't, we also have to understand that sometimes our patients leave hospitals.
Definitely.
They leave hospitals, and what hospital calls it is AMA, against medical advice. But that's very complex. It's not like they're like, peace out, I don't want to be here because I don't want you to take care of me. That's not it. It really is much, much deeper. And so what we really have to do is we have to dig into those pasts and those histories, that what causes a person who is sitting in an ER bleeding from a trauma who says, I got to go.
Yeah.
Why do they do that? When you have medical professionals who are generally willing and able to treat you, but you don't want to wait, or you have something going on that you need to get back to your encampment for. So I think
let's talk about that for a second.
Yeah. I think that's really important to understand that, because people are going to listen to this and they'll be like, hospitals are doing a terrible job. So hospital discharges for people experiencing homelessness are rough. Very, very rough.
For everybody involved.
For everyone involved. But it's not always the hospital sending somebody out without proper care. So I want to make sure that somebody doesn't hear this and say, oh, you're blaming hospitals. I'm not all the time. There are a lot of times when that happens. So I'm also not letting them off the hook.
Sure.
But I have to give my patients some of the responsibility in leaving those hospitals. So when you have people who are experiencing homelessness and it comes to healthcare, there is a lot of stress and trauma related to healthcare. I call it healthcare trauma. People who are experiencing homelessness do not get the same healthcare, the same attention, the same respect that you or I do. So you brought this up in one of our previous podcasts, where it's very common for adults experiencing chronic homelessness to have been homeless as a child.
Yep.
So for a lot of our patient populations, this trauma goes back to childhood. This goes back to being the kid that was taken to the ER because your mom couldn't get you into your primary care doctor because they didn't take Medicaid, or because if they did take Medicaid, there was a 1 week wait. I'm going to give you an example of this. So I was a foster parent for many, many years, and I had a baby who was under a year. He might have been a little over a year, but he had an ear infection and it was wrong with him. He had 103 fever. I needed to get him in. So when you have children who are in foster care, they're on Medicaid. And so you have to have a Medicaid provider. So I called the doctor's office and I was like, need to try to get him in. He's sick. I'm afraid he has an ear infection. Okay, we can get you in 7 days. You can't wait 7 days when you have a kid, when you have a kiddo with a fever of 103 who has an ear infection.
That's absurd.
That's absurd. But so then what do? We have to go to the ER. So as a foster parent, you have to make sure the kids are getting the health care that they deserve and they need. And as a medical professional, I'm like, I really don't like going to the ER for what I think is an ear infection because that's not an emergency.
And keep in mind, back then, they didn't have these urgent care centers. Those did not exist.
I'm not that old, Josh.
Back then, when he was a baby?
Yeah,
they weren't.
Years.
They didn't exist yet.
But, well, the other thing is, I think there were a few, but they didn't accept Medicaid.
Wonderful.
Right. Yeah. So then we go into the ER and then people are like, I don't know why you're in the ER because it's just an ear infection because I can't go anywhere else. And that happens to.
So there's gatekeeping.
Yeah, there is. Right. And so I worked in an ER and you would hear that from ER. Like, why can't they just go to their doctor's office?
Let's talk about it.
Their doctor's office won't let them in for a week to 2 weeks or whatever. And so when kids are raised in an environment where they're living in poverty or depending on Medicaid for their health care, it's different. It's different than those of us who are not raised in that environment. And it's not better. And so then as a child, you're being taken to an ER because you have a routine need, but because your parents don't have any other options. So then as you become an adult, that's what you're used to. And then you have that judgment. Well, why don't they go to a primary care doctor? We've all heard it. And so it starts as soon as these kids who are raised in poverty are born, and they carry that with them, and they don't know. The other thing is they don't know any other way to seek health care.
They've never done it. They've never signed up for anything.
No, and even if they have Medicaid as an adult, well, I used to go to the ER when I was a kid. I have a really good example. When I first started this organization, I had a guy who we had helped get off the streets. He was actually the very first patient I ever saw on the streets. And it took us about 6 months and working with him really routinely. And he decided he wanted to get off the streets. So we helped him get off the streets. We helped him get into a transitional housing. And he was in there. And he called me one weekend. It was a Friday. And it was a Labor Day weekend. And he was like, I need to go to the emergency room. And I said, okay, why do you need to go to the emergency room? Well, I can't hear. Okay, let's talk about this. So I said, do you have pain? Do you have drainage? All of the questions that you need to make sure that there's nothing acute going on there. And all of the questions were no, but he lived in this transitional house with a bunch of other gentlemen who had experienced homelessness. And they're all like, this is an emergency. You need to go. And so I said, you don't need to go. I think you probably have a wax buildup. Now I said, call me tomorrow. Let me know. He called me tomorrow. He's like, it doesn't hurt. I just can't hear out of that ear. So we made it through the weekend. He came into our office on Tuesday morning. He had an impaction of wax in his ear. Not an emergency by any means, but he didn't know what else to do.
But think about that. So if, let's say, and this is true of anyone doing anything, if you're doing a thing and it works, you're going to keep doing it.
Right.
So if every day you go to work and you did a cartwheel, a fresh ham sandwich was put on your desk, you would do a cartwheel every time you wanted to get a ham sandwich because it worked. As random and weird and it doesn't make sense and no one else is doing it that way, you're going to do it because it works.
Right.
If you have an illness or an injury and all you know is go to the ER and every single time you go, they fix it.
Right.
Guess what you're going to do?
You're going to go to the ER.
You're going to go to the ER.
Because the other thing that we know about our people who are experiencing homelessness is they don't live day to day. It's a minute to minute situation. Because it's a fight for survival every minute of every day. And so if they have a primary care provider, which many of our patient population do not, but let's just for the
We're going to hit on
sake
that
of
in a
talking.
second, because that's a big deal.
It is. So if they have a primary care doctor and if they're able to call and get an appointment for this ear thing, it's in a week or 2 weeks. But then they have all of these people out here that are their friends whom they trust talking to them saying, that's an emergency. You need to go. They're not doctors. They're not nurse practitioners. They're not medical people, but that's what they know. And so they're going to listen to those voices that are the people they trust saying, hey, this is an emergency.
And think about, so many people have primary care. They have them for years.
Yeah.
Folks experiencing homelessness, by and large, are going to use the safety net hospital whatever city you're in. There's going to be a designated hospital that gets to bill Medicaid a little bit more money because they take in all of the tougher patients.
Right.
So that's the trade-off. Those places do not keep primary care physicians for very long.
Right.
They are often training institutions. So folks will come in for a year, 2 years, and then they're off to the next thing.
Yeah.
So you can't even build a relationship with your primary care. So the idea that why can't you just go to, because it's a different person every time and have to start over.
Yeah. Okay. So with that said, hospital discharges. So we frequently get patients who are being discharged from hospitals with illnesses or injuries that are absolutely going to be worsened by being outside. I'm going to take you back about 9 years to a guy, and we were doing street rounds, and we were at a stop that I call the lily pad, and he would not face me. And this was a guy who had a lot of anger issues, had been in multiple fights, but we had a really good relationship, and he would not look at me. So I just tapped him on the shoulder, turned him. I was like, what is going on? His jaw was wired shut. So he had gotten in a fight. He had gone to the ER. He'd been in the hospital, and part of treatment for broken jaws, a lot of times, depending on where it is to have it wired shut. And you keep it wired shut to keep it in place. I mean, think about this. When you break your arm, you put a cast on it, keep it still. Okay, same thing with your jaw. It just looks a little different. So he was dismissed. He had been street homeless for many, many years, didn't have a place to go, dismissed to the streets. Now, think about when I say your jaw is wired shut, your mouth can't open. So how do you eat? How do you drink?
You create a mush.
Yeah.
A paste of some kind.
Or you do something like Ensure or Boost. That's what you do. However, that's not served in any soup kitchen.
Is he going to put it in his refrigerator?
Exactly.
Cold.
And it's not cheap. It's very expensive.
It's heavy. There's so many
things. Yeah. So the other thing that they did not provide him is wire cutters. Now, the importance, when I worked in a hospital, if we had someone whose jaw was wired shut, there were wire cutters taped to the head of the bed, because in an emergency, if that person starts throwing up, you have to cut those off or they're going to aspirate and it could cause pneumonia and potentially death. So if you have somebody that you dismiss, even when we dismiss people to home, if they had a home to go to, they would have wire cutters for use in an emergency. So he had no wire cutters and he had no way to eat or drink. And that's
a recipe for healing up.
Yeah.
Quick.
Yeah. And that's not uncommon though. We see stories. So last week I sent a text when I knew we were going to be doing this subject on the podcast. And I sent it to several of my street medicine friends and colleagues around the United States. And every single one of them said, I have so many stories of people who have been dismissed from hospitals, people who haven't had adequate follow-up care, people who have been dismissed without the care they need, and it has caused further complications. It is very common. It happens all the time. One of the first patients we ever helped to get off the streets, when we first encountered him, he was in an encampment suffering from pretty significant back pain. And if anybody's heard me talk, they've heard me talk about this story. But so when we found him, we were very concerned because he had some neurological changes. And we're like, we really need you to go to the ER. And he said, I've already been to 2 ERs. And they told me I had a urinary tract infection and gave me some antibiotics and sent me on my way. So we agreed that we would come back the next week. And if he wasn't any better, then we'd help him get to the emergency room. So we gave him some ibuprofen. I mean, there's not much. We don't do narcotics on the streets. We have to be very mindful of our patients and our volunteers. And so we're really careful about the medications we give. But so we went back the next week and he showed worsening signs of neurological damage. And he had been in his tent almost the entire week. He was able to get out the first day, but then after that, he was back in his tent. Now, backstory, he had a substance use disorder. He had detoxed in his tent over a month because he couldn't get out. His friends were bringing him food for a couple of weeks, maybe a week. His friends brought him drugs because they were good friends.
That's what you do.
Yeah, but then you turn into not good friends after, like, it's you or me, right?
Yeah, once there's a scarcity, the sharing stops.
Right. So he had detoxed. So laying there, writhing in pain and detoxing at the same time. Pretty rough scenario.
That's horrible.
It's horrendous.
Imagine the worst flu you've ever had and you have to do it outside.
In pain.
Yeah, it's horrible.
So we carried him out of his tent, took him to the ER, and one of our docs stayed with him. And in the ER, they were like, there's nothing wrong with him. He's drug seeking, all of these things. Disclaimer, there are better drugs on the streets and easier to get than they are in the ER.
They 3D print fentanyl right now, so stop it.
Yeah, exactly.
You think they want hydrocodone?
Right.
Come on.
So they were going to dismiss him. And our doc, I still to this day do not know what the doc said, but convinced them to do an MRI, which is it's not commonplace to do an ER visit with an MRI. But he had osteomyelitis in 2 levels of his lumbar spine. So what that means is the bone of his lower spine was infected in 2 levels.
Does that go away by laying in a tent?
No. And so what was happening was the infection and the swelling was getting worse and compressing on his spinal column and causing those neurological defects.
So that's not pain. That's probably the worst pain someone can feel.
I mean, I think pain is subjective, and
but being set on fire is probably going to be at the top. So like there's probably levels. That's a high level.
That's a high level, and the other issue from my perspective is that it can kill you. Osteomyelitis can kill you. And so he ended up being in the hospital for a month. Over the course of the month, we learned more about him. He was bilingual. He had an advanced degree. But all of these things compounded on him that caused him to be homeless. And the main thing was substance use disorder.
Yeah, oftentimes.
But he was a member of the LGBTQ plus community, and his parents didn't accept him. And so that caused some stress from an early age when he first realized what his sexual orientation was. And so there was a lot of stress involved with that. And then he experienced a really bad breakup. And so what he did for that bad breakup was he turned to more drugs. And then he ended up losing everything. Like he had a really good job on the plaza. He was a restaurant manager on the plaza and had this big storage. He was an artist. So what we learned during that time is the first ER he went to, they did some lab work, did a UA, said you have a urinary tract infection, gave him some antibiotics and sent him on his way. The second one, they said, you're drug seeking. We can't do anything for you. Per his report, wheeled him out in a wheelchair and said, you need to go. Now, that wheelchair was a couple of miles from where his camp was, and he had to walk back to his encampment.
With this infection.
With osteomyelitis. Yeah. So this is a really good example. And the problem is, as healthcare providers, is we cannot get tunnel vision. Just because somebody comes to us and they're homeless and they have back pain and, they do have a urinary tract infection. But a urinary tract infection does not equate to the level of pain and the neurological deficits that he was exhibiting. And so you have to make sure that you're looking at the whole thing. And the problem is that when you have someone sitting in front of you who is experiencing homelessness and has a history of substance use disorder, there's a bias that sometimes occurs with healthcare providers. And so those stories, those happen all the time. I've had stories. I had a patient one time that we had taken him to the ER because he was having problems breathing. He subsequently had a mass in his throat. He ended up getting a tracheostomy. He called us 2 days later. He obviously wasn't talking to us, but he called us, gave the phone to his nurse, and she's like, we're getting ready to dismiss him. I was like, whoa, wait, where are you sending him? And she said, well, he said that he has a generator in his encampment. And so I said, let me ask you a question. Is he on oxygen? Well, yeah, but if we take a concentrator, they can plug it into the generator. I was like, no, wait, you have a 2-day-old trach
You think they have unlimited gas at the generator?
Yeah.
You think the rain's not going to, like, what are you talking about?
But
Like,
it's
this is a
because
cozy
people do not
encampment?
understand, right? Because
That's
our
embarrassing.
patients are not going to speak up for themselves. They're not.
Well, they're
most
also
of the time.
100%. They're also, when they go to the hospital, all of that bias, which we'll talk, I understand the bias. I
Right.
get it. It ain't good,
Right.
but I understand it. But all that bias compels you to shut up.
Yeah, no. I mean, when I talk about the guy with the back pain, he was intelligent, spoke 2 languages, had an advanced degree. He had a voice.
But to the
But he
hospital,
had lost his voice
yes.
in years of homelessness, in years of substance use disorder, and in years of bias. And he didn't feel like he had a voice anymore. So, but with our guy with the trach, I called the physician and I said, look, this is not a safe discharge. Yes, he lives in an encampment. Yes, they have a generator. The generator is not on 24/7. Who's going to do trach care to a 2-day-old trach? Because you're not getting a home health agency to go in there. And I'm not going to pick up the slack in that way. Now, today we would have put him in our respite, but this was 9 years ago.
Respite
when we
is
didn't have
rare.
respite. Right, exactly. And a lot of communities don't have it, and we have limited beds and all of the things. So, but those stories, like those things that I'm telling you, are the reality, the everyday realities of the patients. These are not extreme stories.
No, it's very.
Not extreme stories. And so you tell them, and people are like, well, that's no, this happens all the time, which is why, like for us, I saw such a need for medical respite and why we have a medical respite facility. But it's very common. A lot. Now I'm gonna play devil's advocate here, because a lot of times the hospitals don't know what to do.
Yeah, I think this is the big thing. So, like, I remember I worked at a place called Artists Helping the Homeless. It's a very unique nonprofit in that they do a ton of transportation from hospitals. And our thought was, if someone's getting discharged from the hospital and you're literally not right there, you're going to lose them, because they'll wander off. And when they wander off, they're going to go do things. And I don't blame them. So you got to be there.
Yep.
So we had a really a big network of drivers and things, and we would show up at hospitals all the time. But we had a lot of clients that I don't blame hospitals for being very frustrated with.
Sure.
And that frustration is going to carry from, because they're going to look the same, they're going to sound the same, all the cadence of the bull crap that they're hearing, they're going to put on other folks, and they're not going to really know discern the difference. We had a client, he went to the safety net hospital here in Kansas City more than 1,100 times in a 3-year period.
Yeah.
That's every day,
Yeah.
sometimes twice a day. And he was going to the hospital for self-inflicted substance use. He would load up a rig, he would inject, he would call 911, and when he heard the ambulance, he would inject the rest, and then on an upper, and because he wanted the Ativan from the ambulance folks, he wanted that mix of the upper and the lower, and he would do it every single day. So hospitals are dealing with that guy.
Sure, absolutely.
Then spine infection comes in, smells the same, looks the same, sounds the same to them because they're tunnel vision.
Yep.
If you're in this field, you see the insanely subtle differences in everyone. It doesn't make sense to us that you would see them as the same, but I get it.
Right.
You don't know what you're doing. Don't know what you're doing. You're not in this field enough. And the other thing is hospitals, and I don't blame them, it's frustrating, they don't feel a responsibility to dealing with that. And in fact, it's almost like an aversion to even wanting to take it on. So as quickly as we can resolve this, we can then go back to our normal day of business. Sure. This isn't our responsibility. It's someone else's. And what the hospitals don't understand is it's nobody's responsibility. And the hospitals get frustrated when homeless folks keep coming back, not realizing that when hospitals play a part in the homeless serving system, those ER visits will drop dramatically. But trying to convince them of that is genuinely, in my career, the single hardest thing, the impenetrable group to get to understand homelessness and participate has always been hospital systems.
Well, because what we do for like our street medicine team, we're not a money-making operation.
Oh, you're not?
No.
Free healthcare? You're not making tons of money?
No, but what we're doing is cost savings. But to your point, one of the things that you said is that the hospitals, like, they don't take responsibility in their role. I think that one of the things we try to do is to provide education to social workers, to nurses, to the people who are on the front lines, because if you can educate the people who are right there taking care of people, that's going to have a trickle down effect.
Huge impact.
So one of the things that I have found extremely interesting, and I've really been paying attention to this recently, is with our medical respite, I take all of the intake calls. And generally when the hospital case managers call me, there are two things that come out of our conversation right away. Number one, they're homeless. Number two, they use drugs. And my response is, I don't care. I need to know what their medical problem is, right? Why it's compelling to tell me that someone has a substance use disorder right from the beginning, not saying, hey, they have this massive wound that we need you to help us get healed, or they need IV antibiotics for 6 weeks, or all of the medical thing. You're calling a medical professional to say why you need their help with this individual patient. And the first thing you feel compelled to say is they use drugs.
They are.
And I oftentimes say, I don't care, and then I say, well, I care, but I need to know about the medical.
That's not the issue right now.
That's not the issue. That's not why they're coming to us. I mean, it is kind of mind-boggling to me that if you're calling an agency to get healthcare, that's the first thing. They oftentimes don't tell me that he can't walk by himself. I probably need to know that. I mean, or, there's other things that are not passed along. But then this happens. People are sent to us wearing nothing but a hospital gown.
Oh, I especially in cold weather, when there's a cold weather shelter operation among a bunch of different providers, a lot of them in church basements, not equipped.
Yep.
The amount of hospital gowned folks that show up is shocking.
When I say nothing but a hospital gown,
ass out.
Yes. We had a guy come to respite. Oh, it was probably the first week of September. He walked in. He was crabby. They hadn't given him pain medicine before he left. And this was someone who, a lot of our patients who come to respite have really complex injuries and they need more than Tylenol. And we have the hospitals, take care of that on discharge. But he was hurting. He was able to verbalize after our staff had talked to him a little bit that he was embarrassed because he literally was wearing a hospital gown with it untied. And this is common. We see this all the time. We see it on the streets. We see it in our respite. And I called the hospital and I was like, hey, this is not okay. What I know is that hospitals have clothing. They do. They have a little clothing stock for people who come in, who have to get their clothes cut off after a trauma, who are homeless and their clothes are soaking wet. You can give him a pair of pants. And the other thing about this guy, he had family involved. His sister had literally the week before taken underwear and jammy pants up to the hospital. And she's like, where are those? We don't know. So it's also about respecting people's dignity, so you don't have
there's no billing code for dignity.
Yeah, I know you can't bill for that one.
Yeah.
You can't charge for it. But it's about, and we've talked about this before, recognizing that the person in front of you is a human and they deserve to be treated with humanity, with dignity and respect.
This is a huge one. And you see this all the time. And you see it in the world of homeless services. It really transcends topic. But you have a choice as a human being. At some point, you're going to be asked to serve the system or serve the person in front of you. And when you choose to serve the system, what you start doing is seeing the people as opposition to the system. And when you start defending that, you start losing your humanity. You see it in homeless services all the time.
Sure.
If you're federally funded and this doesn't meet Fed requirements, you're defending Fed requirements over a human. And I see this in the world of hospitalization all the time. Folks will go in there. They want to help people. I mean, to be a nurse is a brutal job. It's a very hard job. It takes a lot of training. You're dealing with a lot of crap. And I can say that it wears you down a bit.
Yeah.
But when you start defending a system that is cruel or doesn't treat people with dignity, like a part of your soul goes dim. And you see this all the time with hospital system, healthcare systems. It's almost always like this conversion. So someone from a hospital system is going to listen to this and they're going to be so mad at us saying, well, they're supposed to da-da-da-da-da. And whatever the supposed to is, is a hospital policy.
Right.
That no human being would come up with because it makes absolutely no sense and all it does is serve the hospital. So stop doing that. Yeah. Just meet us on a human level and say, would you want your mom treated like that? You wouldn't. Even if she didn't know what was going on, even if she was an alcoholic, whatever it was, you wouldn't care. You would want her treated with dignity, especially on the day-to-day basis. But getting ground down into a nub to a point where you can't voice that my spine is infected, so just kick me out.
Yeah.
That's devastating.
And then to be scared to go back. Because of
why did they go back?
Right. No, and because they had already been to 2 ERs.
And perhaps there is an achievement for the healthcare system in that outcome. So, certainly. Now, one of the more frustrating parts
that would be, but
they're not coming back, not costing us money, not wasting our time. So, one of the folks are going to be hearing this and they're like, well, you're going to save hospital systems money. So wouldn't they want to give you money? You would think.
Yeah, you would think.
They don't do that. So let's say, and believe me, we try all the time and we're never going to stop trying because eventually there's going to be a leadership there that gets it.
Yeah.
But we will, let's say you go to the health, and KK does this all the time. You could save a hospital system $2 to $3 million in a set of 20 to 30 patients, if they were the right 20 to 30 patients, without 1,100 times in 3 years. That was one guy.
Yeah.
That's millions of dollars, one dude. So you could go and say, we're going to save you $4 million. Give us $1 or give us 25 cents for every dollar we save you. That's not what they do.
No.
You could save them $4 million, and what they'll do is they'll give you $25,000.
Yeah.
They don't count it like you think.
It's because it's not money making. Their bottom line is different.
Very different.
It's very different.
You have to recognize, anyone who's frustrated about, just recognize hospitals don't count it that way.
No. And hospitals are businesses. We have the problem of healthcare and healthcare entities, and that's a whole other podcast. But that is a problem. That is a problem. Meeting the requirements of insurance companies.
Yep.
And you have to have a certain, diagnosis to admit people. I'm going to say one thing about what we've discovered in having medical respite. I can say to a hospital, hey, maybe it's a Tuesday, and I'm like, I'm going to have a discharge on Thursday. We'll have the room ready on Monday. Can you hold them? 9 times out of 10, that hospital will hold them.
Now we're talking.
So for me, that's a small win.
That's a huge win.
Because not because of us, but because that patient now has a place to go.
Yes. And
it's a safe place. We weren't like that at first. When we first started respite, people would be like, no, we can't hold them. And I would say, well, you can. Now, granted, I'm talking to case managers who are getting pressure from above them to get people out the door. Because that happens. People don't understand. Whether you're talking about people who are experiencing homelessness or those of us who are housed with insurance, when you walk in the door, they start looking at, why are you here? What is keeping you here? How much are we getting paid for this? And when do we need to get you out the door? And so that sounds really brutal, but that's the reality of the way it works.
We have to talk about how it is.
Yeah. And so we have had those small wins where I'll say, if you can hold them till this time, not everybody, it's not every time, but it is more often than not now that hospitals are saying, yeah, if you can take them, and I'll say, yeah, after we go in and we evaluate patients, because they forget to tell us they can't walk or they can't put their pants on by themselves, so we can't take care of them, right? So we have to go in and evaluate them. They're going to tell me that they have. It
really is that simple. People need to know, you have to ask those questions.
Yeah, we shouldn't have to ask those questions. But I never have to ask if they have a substance use disorder. Never, because it's one of the first things that I'm told. Can you tell me if they can feed themselves? They
have a horrific burn, but that's what we're talking about?
Yeah.
Yes.
So I think that it's very complex. It's complex for the hospital systems. It's complex for our patients. It's complex for us. But I think we have had some small wins. I think that the hospital systems have got to see the value in street medicine, and in some communities they do value them, and they provide really good support for the teams that are doing this. But street medicine teams save hospital systems hundreds of thousands to millions of dollars every year because they're doing that preventative care, which we talked about in, I think it was week 2.
Go back and watch all of our.
Watch them all. Well, there's only.
So
I don't know.
Hospitals this is the part that frustrates me. They do not want homeless folks in their ER.
No.
They do not.
Nope.
If you don't want homeless folks in your ER, you must invest in the homeless serving system.
Yeah.
The homeless serving system is not thinking about you, hospitals. And hospitals often they're angry that the homeless system isn't concerned about their ER issue.
Right.
Homeless shelters aren't thinking about you.
No.
It is.
They can't.
They can't. They're not like, why would they consider you? They're not. They can't.
Right.
They're so busy. Hospitals, if you want dedicated beds, pay for them. It is the cheapest investment. Your health savings, the cost savings are going to be a revenue stream.
Yeah.
But the only way to guarantee that discharge is safe is if you are helping to fund and create those beds.
But then from a humanity level, you've got to do the right thing by the people who are sitting in front of you. They're not, I think that's where, for me, it gets a little bit tough, is that not recognizing that a person who is being dismissed to the streets with their jaw wired shut is going to die out there because they have nothing to eat. And if they start vomiting, they could potentially choke and get pneumonia and die. I mean, I think that's where some of those thought processes I don't understand. And we have to get people back to the humanity side of the medicine that is practiced in hospitals.
Well, we all know that that's not going to happen until a meteor resets how we all live, because healthcare is a commodity the same way housing is.
Yeah.
It is a stock or a bond that is traded, which is why places like Care Beyond the Boulevard have to exist.
No.
All right.
You ready for your favorite part?
Yes.
Let's get to those questions. Jackie.
Okay, I have a question that's probably for both of you. So let's just see.
Okay.
I'll throw it out and see who answers. It's a two-phase question. What are the metrics we should be measuring to better align cost savings care versus profit-based care? And the other side is, who should keep the systems accountable to those metrics?
What a great question.
Yeah. So the metrics, that's hard though. And I think we talked about this maybe in week 1 or 2. I can't remember.
You should go back and check out our other episodes.
Hey, maybe go listen to our other episode. Plug.
Yes.
That was shameless. Okay.
Why would we? What were we going to dance around it?
No,
where are you
don't
gonna
dance. We're not dancers.
Where are you going to learn about homelessness? It's here.
Right here.
What are you talking?
Okay.
Are you going to watch a PowerPoint?
Hey.
You'll come crawling back.
Let's talk about that.
All right.
Okay. So the problem with that is that metrics for homelessness and hospitalizations are very difficult, particularly in a large metro, because you have so many hospital systems that don't talk to each other. And when they don't talk to each other, they don't know that this hospital, some of them can get some records in. So don't get me wrong there.
But it's not standard.
No,
it's a whole thing.
It's supposed to be, but it doesn't work quite like it's supposed to. But they don't know that this person was seen at this hospital last week for the same thing and dismissed, and it continues. And so what you have to do is you have to create a system. There is something in Kansas City anyway, and I know other cities have this, where they have high utilization. But what it is it's a group of individuals from hospitals, EMS systems, that come together, and they're like, okay, this person was seen in multiple ERs this week. A lot of times, I used to sit in on those meetings, but a lot of times they're not talking about people who are experiencing homelessness. Sometimes they are. But it was really a lot of information about patients that we didn't touch. And I felt like my time could be better utilized somewhere else. But systems have got to figure out a way to, number one, identify people who are experiencing homelessness. And you can do that in the ER. You can do that. There's a way to do it. The problem is, when you check into the ER, they ask you, we have your address as 711 Virginia Avenue, which is a homeless service center, Hope Faith, right? And so they get mail there, and they say yes. Now, the person checking them in does not know that they're homeless. And then the case manager doesn't know that that's a homeless service agency.
They think it's an apartment.
Yeah, right. And so, and they don't ask those questions. Do you live outside? Even for us, when we're seeing patients, when I have students, I say,
we got to answer this question.
Hold on.
We're like dancing around it.
You danced first.
This took way too long. Will you say the question again?
Hold on.
What metrics need to be measured and how
I told
cost
you.
savings happen as a result of those metrics?
What are the metrics we should be measuring to better align cost savings care versus profit-based care?
Admissions, ER visits. But the problem is you can't easily do that in a city where you have multiple systems.
Imagine the 1950s. Like, think about how easy it was to commit crimes in the 50s and 60s. Literally, all you'd have to do is go one town over.
Yeah.
Because they didn't talk to each other. It's still that way with
In
homeless
hospitals.
care and hospital systems. So you have the conversion of two siloed organizations or systems. Not even so. Like, hospitals don't understand how there is no homeless system to plug into. It's just a collection of nonprofits that are very independent.
Yep.
The hospital systems are the same
Yeah,
way.
they're the same way. So you've got to build it. That's the first thing that has to happen. You
Build
have to
what?
build a way to communicate for hospitals. Each hospital has to collect the data. Like, are these people homeless? Is this individual homeless? And the questions have to be asked.
Yes.
And that's what I was getting
But
to.
what
when you
KK is saying,
He interrupted me.
you have to have a data system
Yes.
that both the homeless serving agencies as well as the hospitals are connected to.
Right.
That's step
But it's
one.
got to start in the hospital, right? Because when they say, what's your address? They put it in there. They're done. No, end of discussion. They don't say to them, do you live inside or outside? You have to ask those questions of people, because the other thing is our people are not going to answer them. They're not going to idle live. I'm homeless.
Yeah, but imagine if the hospitals were connected to the system and
Then
they
they
could
could
see
see it.
boom, 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 boom. Okay,
Yeah.
well, this requires something. The other thing that happens when you have a system that's all talking to each other is it informs all of these systems where money should go.
Right.
So they're not even measuring correctly at all what it would mean to prevent this group from not utilizing these services, and then the fraction of the cost to serve them in a way that would prevent them from doing that.
So I think one of the things that this could be done, it can be done. Don't get me wrong. It can be done.
Yes.
But it's going to take a lot of work. One of the things that I think needs to happen is you need to take a small number of individuals who are experiencing homelessness and then take their information, and then us, our street team, work with those hospitals that have that information. And when the patient is identified as being homeless, then they involve us in their care and then watch. And then you take, they would have to identify from the point of entry if they're street homeless or not. You have a control group, and then you have
this is insane.
another group.
No, everyone's checked out of this.
No, well, but they shouldn't
is
be.
insane.
No, they shouldn't be.
They should.
Because
You're talking about control groups?
yes, because
You're
listen
talking about
to
a
me.
pilot program?
I am, because it's not going to work any other way, because you have to think how hospitals do, and you don't. And the problem is that if you don't
This is taking forever.
Yep.
What's the next question? Is that it?
Yes.
That's it?
Yes.
Oh, that was the least compelling we've ever done in Ask the Expert. That was horrible.
No, because there's
Horrible.
no
Terrible.
good answer for it.
There is. Yes, there is.
What's your answer?
There absolutely. Okay, so the question is.
But you have to think like a hospital system. You can't think like a city system.
I certainly do not. If I think like a hospital system, all of this won't work. Hospital systems have to think differently if they actually want to solve this problem.
Mm-hmm.
The number one thing you have to have is a data system where everyone is talking. You have to know that patient A is going to this hospital up north, this one out south, this one. Okay, so that's going to change how you're going to orient care for this person. They're doing this. They're pretty mobile. You're also going to need all of the homeless serving systems as part of it. So now when you're looking this person up, there they are.
But
they're connected to this. The problem, hospitals don't ever want to connect to the homeless serving system because they're saying our data is too precious to share with anyone. They do this all the time. If they want cost savings,
Yep.
they must do this.
Now,
If not, they're going to be complaining about ERs until the end of time.
now listen to me. Let me finish. Don't tell me it's horseshit. Listen.
I can tell you that.
No, just wait. But the thing is that for hospitals to see that value in what you're saying, they need a small number to show that value.
But, okay,
they're not going to
bake
just start
that
doing
in.
it.
We're just talking broadly
Right.
what we're doing. We're not saying left foot, then right foot, and then you create a chart. Yes. Do we need a pilot? Perhaps we
Yes,
need
we
to
do.
prove efficacy.
Yes.
But in general, hospitals have to, they can't think like hospitals if they want to solve this problem. It is that simple. They cannot. They will fail
But you
every
got
time.
to start small. That's how they do everything
For
in
sure.
medicine.
For sure.
Everything in medicine.
Yes.
Okay,
It
so we
was
agree?
easy to make fun of you on that.
Yeah,
That was
don't.
all. It was. I found a way. I'm like water. If there's a gap, I'm going to find it.
Yeah.
That's going to be it.
All right.
Is that it? Did we do
That's
it?
it. Did we answer the question?
We did great.
Yeah, really.
Did we do great, Josh?
KK has a very unique perspective on this topic, and I think it's probably going to come up again. I think talking about how healthcare intersects with homelessness is, I don't know, its overlap is like 85% of all of homelessness.
Absolutely.
So,
we know that healthcare is healthcare is housing. We know that in integrating healthcare into someone's life who is experiencing homelessness is going to actually help them get out of homelessness and stay out of homelessness if they continue to get that healthcare that they need.
and healthcare isn't free, and
Nope.
you are providing it for free.
We are.
So please support organizations in your community like Care Beyond the Boulevard.
Join us next time on Untangling Knots, where we're going to continue to explore the challenging realities of homelessness without the sugarcoat.
Here we go. Thanks for watching.